Diabetes in pregnancy, sometimes it is normal and sometimes it becomes a topic to worry about. In this video, we will talk about both the condition and will figure out every important aspect related to this obstetric condition. So hi everyone, I'm Dr. Taiyab Khatry. वेलकम बैक टू आवर मेडिकल यूनिवर्स। अगर आपने अभी तक चैनल सब्सक्राइब नहीं किया है तो प्लीज डू सब्सक्राइब एंड प्रेस द बेल आइकन टू गेट अपडेटेड विद द लेटेस्ट वीडियोस। Diabetes in pregnancy is either gestational diabetes or overt diabetes. So before talking about the diabetes in pregnancy, let's see a case. A 28-year-old G4 P2 comes to your OPD for a routine prenatal visit at 24 weeks gestation. Her physical examination is unremarkable and fetal well-being is reassuring. You recommended testing for gestational diabetes to get confirmed if the patient has GDM or not. So, should everyone be screened for GDM? The answer is yes. The ideal time to screen for GDM is 24 to 28 weeks of gestation. And for the women at high risk of developing GDM, early screening for GDM is recommended at the first prenatal visit. If the early screen is negative, it should be repeated at 24 to 28 weeks. For this, you will perform DIPSI test. Generally, while performing a diabetic test, we ask patient to come empty stomach or in a fasting state. But in GDM, there is no need of fasting. We ask patient to ingest 75 grams of glucose. Then later, after 2 hours, we will check patient's blood sugar. This is called 2 hours oral glucose tolerance test. After 2 hours, if the patient's blood sugar is more than equal to 140 milligram percentage, then this confirms the patient has GDM. So what is GDM? GDM occurs due to insulin resistance due to secretion of human placental lactogen during the pregnancy. In GDM, there is no risk of congenital malformation of fetus and usually no treatment is required because GDM does subside itself after the delivery of the fetus. But if it does not subside even after the delivery, then we will give insulin to the patient. Now the next one is overt diabetes. If we talk about overt diabetes, let's see how this patient will present. A 30-year-old G3P1 comes to your OPD with positive pregnancy test. The past medical history or obs-gyn history tells that the patient has had a history of GDM and a prior macrosomic infant and a prior unexplained late fetal demise. Her physical examination is unremarkable. You recommended blood sugar testing to get confirmed. Again, we will do 2 hours OGTT in which we ask patient to ingest 75 grams of glucose. After 2 hours, if fasting blood sugar value is more than equal to 126 milligram percent, the random blood sugar value more than equal to 200 milligram percentage and the glycosylated hemoglobin HbA1c value more than equal to 6.5%, this will confirm that the patient has overt diabetes. Now, overt diabetes is a condition which presents in a patient before getting pregnant and remains after the delivery of the fetus. Simply we can say a diabetic patient becomes pregnant. See, as we already know, the ideal time to screen for diabetes in pregnancy is 24 to 28 weeks of gestation. But in the overt diabetes, the patient has high risk of diabetes in the pregnancy. So the early screening for the diabetes is recommended at the first prenatal visit. It is seen with only 10% population and the risk of congenital malformation in the fetus is very high. So talking about the investigation, the best investigation to detect congenital malformation in fetus is level 2 ultrasonography, which is also known as TIFA scan. It is usually done in 18 to 20 weeks of gestation. Best investigation to predict congenital malformation in fetus is glycosylated hemoglobin HbA1c value. Most common system affected in congenital malformation in fetus is cardiovascular system, followed by CNS. Most common congenital malformation in fetus is ventricular septal defect, followed by neural tube defect. Most specific congenital malformation in fetus is caudal regression syndrome or sacral agenesis. Most specific heart disease in fetus is transposition of greater artery, TGA. Now, how will you manage this patient? To manage this patient, first we ask patient to do diet modification with regular exercise for 2 weeks and ask patient to keep fasting blood sugar level lower to 95% and HbA1c level lower to 6%. If patient fails to do so, then we will put patient on insulin, and insulin is the drug of choice of diabetes in pregnancy. Now, what are the time of delivery of fetus in GDM? If the GDM is controlled with diet modification, the delivery of the fetus will be on expected date of delivery, that is after 39 weeks until 40 weeks plus 6 days. If the GDM is controlled with the insulin, the delivery of the fetus will be after 39 weeks until 39 weeks plus 6 days. If it is a case of an overt diabetes, the delivery of the fetus will be 37 weeks to 37 weeks plus 6 days. There are so many complications of diabetes in pregnancy, both maternal and fetal. Talking about the maternal complication, these are polyhydramnios, malpresentation, preterm labor, premature rupture of membrane, postpartum hemorrhage, abruptio placentae, or prolapse. Talking about the fetal complications, these are ventricular septal defect, neural tube defect, caudal regression syndrome, or sacral agenesis, TGA, and shoulder dystocia. Now there is one very important fetal complication of diabetes in pregnancy, and that is shoulder dystocia. So what is shoulder dystocia? It is a very important clinical aspect. So let's talk about it. In gestational diabetes, the maternal blood sugar level increases, which results in increase in fetal blood sugar level also. Due to this, insulin level in fetus also increases, and insulin is a major growth hormone in fetal life. So this increase in insulin level causes overgrowth of fetus, which is termed as macrosomia. So macrosomia defines as large for gestational age, as you can see in this image. Due to this increase in insulin level, the excessive fat deposit on the shoulder of the fetus, which eventually stuck in the pelvis during the vaginal delivery, and this is called shoulder dystocia. Now, how will you manage shoulder dystocia? The first line management of shoulder dystocia is shoulder dystocia drill, in which we apply a suprapubic pressure to the mother. Remember, fundal pressure is contraindicated here. We will not apply pressure on fundus. If this fails, then we will do 3 maneuvers. The first maneuvers and the best maneuver is McRoberts maneuver, in which we do sudden flexion and abduction of maternal lower limb. There is a complication of McRobert maneuver. The complication of McRobert maneuver is injury to lateral cutaneous nerve of thigh of the mother. Now, if the McRobert maneuver fails, then we will do the second maneuver, and it would be Wood's corkscrew maneuver, in which we rotate fetus shoulder by 180-degree angle. If this also fails, then the third maneuver would be Javanelli's maneuver, in which we push the fetal's head back inside the uterus and will do a cesarean section and bring the baby out of mother's womb. Now, talking about the causes of shoulder dystocia, the most common cause of shoulder dystocia is gestational diabetes or a diabetic mother. The most common maternal complication of shoulder dystocia is postpartum hemorrhage. The oral hypoglycemic drugs are contraindicated in pregnancy, but we can give metformin and glyburide. So thank you. Do follow, share करें, subscribe करें, and comment if you have any queries.